Welcome to the lecture on substance use disorder or addiction. Before we get into looking at everything in our module objectives, let's discuss this. Are addictions a medical disorder, a medical illness? Yes, addictions are a medical illness. They are chronic and if left untreated, progressive, and they're characterized by remissions and relapses. Understand, this concept of addiction or substance use disorder being a medical diagnosis is not fully supported in the medical community. Some practitioners still believe that people with addictions should just pull themselves together. Well, let's look at the definition of a disease. Right there on your slide. So, a disease is characterized by at least 2 or 3 criteria. So in substance use disorder, is there an agent or causative etiology? Yes. When you get to the etiology notes, you too will be able to support that. Are there identifiable signs and symptoms? Yes. When you get to the notes on signs and symptoms for intoxication, overdose, and withdrawal, you'll see that. Do substances change the body or body systems? Yes, absolutely. You will see in your PowerPoint slides and in your text that that's true. Alcoholism is responsible for 30% of all inpatient hospital days and nearly 50% of emergency room visits. Substance abuse. I want to point out something on these voiceover slides. When you see a grayed out area like this, that's an active hyperlink in your non-voiceover version of the lecture. Please pull that up and pull up those hyperlinks to learn more about whatever it's linked to. So, substance abuse and related disorders are a national health problem. The current data says that about 10% of the 18 and up population is in recovery from drugs and alcohol. The CDC says there's approximately 88,000 deaths attributed to excessive alcohol use each year in the United States alone. This makes excessive alcohol use the 3rd leading lifestyle-related cause of death for our nation. Excessive drinking is responsible for 1 in 10 deaths among working age adults between the ages of 20 to 64. The most recent data says that the economic cost of excessive alcohol consumption is nearly $250 billion a year. About half of all motor vehicle accidents are related to alcohol. Babies are born addicts. Mothers and families are addicted to prescription drugs, alcohol, and illicit drugs. Alcohol or drug addiction is implicated in all forms of violent and many non-violent crimes. Children of alcoholics are 4 times more likely to develop problems with alcohol, and 20% of those who commit suicide are alcoholics. As a nurse, you can educate and raise awareness. Many people in recovery report having their first drink when they were younger than 10. Nurses work in prevention and treatment, and we can make a big difference by reaching out to children before they start drinking. Got some important terms. As we know, understanding terms really helps you as you learn to understand the data on your slides and in your chapter. What's intoxication? That's the use of a substance that results in maladaptive behaviors. Withdrawal symptom is the negative physiological and psychological reaction that occurs when substance use is decreased or eliminated. Detoxification is safely withdrawing from a substance. Substance abuse is the use of a substance in a way that is inconsistent with medical or social norms and despite negative consequences in social, vocational, or legal areas. Substance dependence, also called addiction. Those are problems associated with addiction, such as tolerance, withdrawal, and unsuccessful attempts to stop using. We call that relapse. Abuse and dependency are different due to the ICD numbers. ICD numbers are how we charge for certain services. Tolerance, that's when you need more and more of a substance to produce the effect from a previously lower intake amount. Let's look at etiological theories for substance use disorder. The primary biologic risk is genetic influence or genetic vulnerability. Children of parents who are alcoholics are more likely to develop alcoholism and drug dependence. The neurochemical influences that are being studied show us what we pretty much already know. Mood-altering substances stimulate the dopamine pathways. In other words, you feel good. And while most people have a control, some lack that and continue to drink past pleasure. Psychological and family risk factors include inconsistency in the parent's behavior, poor role modeling, and lack of nurturing. This leads to a lack of adaptive coping skills, and substances become the coping mechanism to relieve stress and tension. Substances can increase feelings of power and decrease psychological pain. Possible influences of social and environmental factors include culture, social attitudes, peer behaviors, laws, cost, and availability. There's a theory that urban living coupled with high crime rates, high unemployment, and substandard school systems are possible factors in developing a substance abuse problem. But folks in the country also have substance abuse issues. They have their own strains and stressors that are not common to urban living. The graphics in this slide are from the NIH. They show the suspected etiology and risk factors. Please feel free to pause these. And on your regular PowerPoint, you've got a link to a really well done explanation about the science of addiction from the US government. And if you think recovery treatment in your area may be an interesting area to work, there's an NIH site also listed in your notes for healthcare professionals to learn more about working in recovery treatment. Let's look at cultural considerations. Cultures and religions view alcohol and drugs differently. For instance, kosher wines are an important part of religious rituals at the Jewish holidays. Muslims are not allowed to have any alcohol at all. Native Americans may use peyote in religious ceremonies. Native Americans also have one of the highest rates of alcohol dependency. Alcohol is in fact a component in the 5 leading causes of death for Native Americans. Japanese seem to metabolize alcohol differently and consume much more alcohol than Caucasians. About 50% of Asians cannot metabolize alcohol properly and will experience facial flushing and palpitations. This is extremely unpleasant and we think may prevent abuse. And some ethnic or cultural backgrounds just simply drink more than others. For this class, we'll briefly review the classes of substance listed, effects of intoxication, overdose, and withdrawal, and detoxification, and then examine the application of the nursing process with substance abuse generally, but really more specifically with alcohol. We're really mostly going to focus on alcohol. The link here takes you to the NIH to learn more about common drugs. Click on one of the drugs while you're there. Learn a little bit about the street names, the commercial names, the forms, and how it's taken, the health effects, as well as the treatment options. All right, here we go. All right, we'll start with nicotine. Cigarettes are the primary delivery method for nicotine. Cigarettes are not just tobacco. It takes an awful lot of chemistry to slow the burning of tobacco, to add flavor and other methods to make the experience of purposefully inhaling the results of a burning fire to be pleasurable. So, cigarettes have 70 cancer-causing chemicals. The medical comorbidities are listed, and you'll notice a strong correlation between other addictions and a nicotine addiction. Frequently, those with a substance use disorder for another substance also smoke cigarettes. There's also pregnancy risks. Mothers who smoke have low birth weight babies, and the babies tend to have an increased risk of congenital abnormalities and asthma. So for med-surg, you may encounter a patient addicted to nicotine with a patch or gum. Those are ordered. It's important you understand how to administer the nicotine patch, use different locations on the shoulders and arms, and then each dose is in smaller and smaller amounts of nicotine. The gum, you'll see right here, there's directions, and there's also directions on your package of gum. Sedatives, hypnotics, and anxiolytics. Remember, anxiolytics, sedatives, and hypnotics are drugs that work on the central nervous system to treat anxiety and insomnia. If you don't remember what those drugs are, go back to the chapter on pharmacology to refresh your memory. Barbiturate typically has barb in its name. Barbiturates are the most abused drug in this category and produce effects similar to alcohol. Barbiturates were very popular in the 60s and 70s. They're also called downers, reds, or poppers. So, intoxication, you have slurred speech, lack of coordination, unsteady gait. ODing on a barbiturate can produce stupor, coma, respiratory arrest, and death. Barbiturate overdose was listed as the cause of death for Marilyn Monroe. Michael Jackson had 2 barbiturates in his system, as well as the propofol. Propofol is a sedative. Withdrawal from barbiturates is very dependent on the drug and its half-life. Some drugs you will withdraw from that day. Others, it can be a week after discontinuing it. The symptoms of withdrawal from a barbiturate produce the opposite effect of the drug. So you'll become agitated, have elevated vital signs, experience tremors, insomnia. If barbiturates are abruptly stopped, patients can experience coma and death. It's extremely important when they stop these drugs that they taper off slowly. This is a big safety concern. Stimulants. Stimulants include, for our lecture, amphetamines and cocaine. These are highly addictive drugs. Cocaine was once touted as a medical miracle about 100 years ago. I think I mentioned to you once that Freud had cocaine psychosis. So, stimulants are popular recreational drugs because of the intense and immediate euphoria. Cocaine costs about $50 for a gram, and a rock of crack is about $10. A rock of crack costs, I said $10, that's also called a dime of crack. So crack tends to be used by less affluent users. Coke is snorted, crack is smoked. Crack can also be cooked down with vinegar and lemon juice and injected. Ugh, think what that does to your veins. So where do we find amphetamines? Legally, methylphenidate, which is Ritalin. Students will sell their Ritalin for about $2 to $5 a pill. It's very popular during finals time in high schools if you happen to be a school nurse. There are some diet clinics that still prescribe amphetamines. Amphetamines are also called diet pills, speed, or greenies. Lower quality speed or lower quality amphetamine is called crank. Crank can be snorted or injected, and a hit costs about $10. Ice or crystal meth is also called Tina, and that is smoked. On this and the next slide, it shows the effects of stimulants on your body. Please feel free to pause this at any point and read through the pictures or go to your PowerPoint that's on Blackboard and look at the pictures there. So, intoxication for stimulants. You have physical signs. Your physiologic signs are dilated pupils, chest pain, tachycardia, tachypnea, and hypertension. Your psychological signs of intoxication, well, like I said before, central nervous system stimulants produce a high or euphoric feeling. There's hyperactivity, hypervigilance, insomnia. People exhibit assaultive behavior. They show grandiosity. There's definitely impaired judgment and impaired social and occupational functioning. Overdose signs and symptoms of stimulants include respiratory distress, ataxia, an elevated temperature or hyperpyrexia, convulsions, and also you can have seizures, cardiac arrest, coma, or death with an overdose. Withdrawal. Withdrawal can happen in hours or can take several days. Withdrawal signs and symptoms include dysphoria, fatigue, vivid and unpleasant dreams, insomnia or hypersomnia, so you're either not sleeping at all or sleeping way too much, increased appetite, psychomotor retardation or agitation, anxiety, apathy, craving for the drug, and depressive symptoms, including suicidal ideation for several days. Most withdrawal with stimulants is treated supportively to support physical integrity. That means things like fluids, helping people rest, food. More aggressive treatment is treated in an emergency situation with medications to manage the symptoms. You can see in this one too, you've got long-term effects from a meth user and the oral effects called meth mouth. Hallucinogens distort the user's perception of reality. Hallucinogens are usually naturally occurring substances like mushrooms, or they can be made by chemistry. Chemistry is things like ecstasy and PCP. Intoxication with hallucinogens. People exhibit maladaptive behaviors and psychological changes such as anxiety, depression, paranoia, ideas of reference, and dangerous behaviors like thinking you can fly. Although the drugs do not directly cause the death, they impair people's judgment so much that the drug is an indirect cause of death by things like suicide or accidents. For PCP, which is also known as angel dust, toxicity, the treatment is supportive. Remove the stimuli. People may need restraints. They may need cooling devices with PCP, and sometimes patients have to be put on mechanical ventilation. Withdrawal, some people report craving the drug, but the primary issue is flashbacks, which can go on for months or years. Inhalants. Inhalants are primarily things like glue or gas, paint thinner, paint spray. I understand now the spray paint is locked up and you have to be 18 or 21 to buy it. That has to do with kids inhaling the vapors that are in the spray paint cans. These can cause significant brain damage, inhalants. Intoxication is dizziness, lack of coordination, tremor, blurred vision. And for overdosing, that's acute toxicity. You'll have anoxia, that's a lack of oxygen, respiratory depression, vagal stimulation, and dysrhythmias. People who use inhalants can die from bronchospasm, cardiac arrest, suffocation, or aspiration. There are no withdrawal procedures. People who use inhalants report cravings, and if they do OD, there's nothing to treat them. Persistent use of inhalants can cause dementia, psychosis, anxiety, and mood disorders. Treatment is just supportive. Remember, supportive treatment has to do with ensuring people get rest, fluids, food, are not overstimulated, things along those lines. Opioids are a central nervous system depressant. They cause feelings of euphoria and desensitization, which is generally a feeling of general well-being. Opioids include prescription drugs like morphine, Demerol, hydrocodone, And street drugs like heroin, or something some of you may not have heard of, purple drank, D-R-A-N-K, which is also called lean. Lean is what I'm going to call it, is a mixture of Phenergan and hydrocodone cough syrup. You mix that with a Sprite and a Jolly Rancher and drink it. I bring up lean because lean is very popular in Texas. It was actually started in Houston and has been popularized in rap and hip hop, which was generated by Third Coast groups or individuals. Third Coast is Southern rap. Some of you may or may not have heard of DJ Screw. He was a Houston rapper. Some of you may or may not have heard of Pimp C. He was a Port Arthur rapper. Both of them died from lean. Opioids are also strongly associated with criminal activity. So for intoxication, users feel apathy, lethargy, impaired judgment. You'll see constricted pupils, slurred speech, impaired attention span and memory loss. Overdose can result in respiratory depression and death. Narcan and supportive therapy like IV fluids, oxygen, positioning to prevent aspiration, removal of stimuli, things along those lines are used if people are overdosed. So for withdrawal, initially patients are anxious, they have muscle aches, craving for more opioids. As the withdrawal continues, patients develop nausea, vomiting, diarrhea, dysphoria, anhedonia, and fever. And withdrawal is extremely uncomfortable. Sometimes heroin users are put on methadone and the dose is tapered off to reduce the symptoms, so it's just more flu-like. Some of you that are going to work in the nurseries and in postpartum will see babies who are withdrawing from mothers that used opioids during the pregnancy. Those babies scream a lot because the withdrawal is very painful. So your next slide is going to have more details on drugs used during treatment for opioid and alcohol treatment. So you're going to want to refer back to that slide 16 when we talk about alcohol. So your textbooks has great resource tables for pharmacotherapy used with substance abuse treatment. Look this table over and get an understanding for which drug is used for each substance abuse treatment. Don't think I need to read the tables to you. Look at the nursing considerations, why I like this table a lot, for the use of these medications in the treatment of substance disorder. And please remember to refer back to this when you're looking at the treatments for opioids and for alcohol. You can pause the PowerPoint at any time, and you also have this slide on your non-voiceover one on Blackboard. Pain management treatment for patients with substance use disorder. That's patients that are also addicted to opioids at the same time. When somebody's admitted or in the physician's office, you're going to be involved in using a screening tool like the CAGE-AID or the COWS, C-O-W-S, which is the Clinical Opioid Withdrawal Scale, as part of the admission assessment. During admission, we want to ask some pretty straightforward questions like, do you take any medications for pain? And if their answer is yes, get the name of the drug, the frequency of use, the route, the amount typically used, and the duration that the patient's been using that drug. Ask specifically about opioids when taking a substance abuse history. So after you ask a question about alcohol use, you can say, do you use any other drugs? Then name the opioids like OxyContin or Vicodin or codeine. There's some red flags used to detect opioid dependence with patients. You'll see that they have pain. Frequently, they describe it as orthopedic pain, but there's no documentation or imaging to support that. They may request a specific opioid for pain management. Some will show little interest in their physical exam, the diagnostic tests, or any non-pharmacological remedies. Some will talk about changes in work or relationship status. They may cease to participate in activities. This is an indication of social isolation. There also may be indications that the patient's spending a great deal of time in pursuit of opioids, such as doctor shopping. So if you notice any of those things, be sure you let your doctor and charge nurse know. Now, if we get a patient in med-surg that also has a substance use disorder with opioids, in other words, they're addicted, we will do the screening like we talked about, and then we're going to use a multimodal approach to ensure adequate pain control. First off, we want to prevent withdrawal symptoms. So the doctor may order an opioid because recovering from surgery or while you're in rehab, we're not going to bring on those painful symptoms of withdrawal at the same time. It's important that you as the nurse take a non-judgmental approach to the patients. We may be treating concurrent psychological disorders, and you should expect that there may be some dosing differences. These patients may need higher doses because they metabolize their meds and sense their pain stimuli differently than patients who don't have a substance use disorder with opioids. We may end up using some long-acting pain medications to control breakthrough pain. And another thing that we could be using is regional pain techniques like nerve blocks for local pain. Let's talk about cannabis or marijuana, also known as pot, Mary Jane weed, and about 1,000 other things. Cannabis is a plant that produces psychoactive effects when taken as an inhalant or eaten. It's the most widely used illicit drug in the United States. Pot, this picture shows you the effects of THC, which is the active ingredient in marijuana, and what those effects are on the brain. So for intoxication, people feel similar to alcohol. They have euphoria. Pot produces impaired judgment and short-term memory loss. People have bloodshot eyes. They get hungry or the munchies. They have hypotension and tachycardia. Try to think of pot as a dimmer switch for the brain and body. That's basically what it does. It kind of just turns everything down. Overdose? Well, there's actually no documented incidence of overdose, but there's incidence of over-ingestion with edibles, especially if the person has never used pot before, and a few incidents of bizarre behavior following ingestion, which included homicide and suicide. So, is it the pot, or did the person have an underlying disorder? We don't know. And those incidents of homicide and suicide following ingestion of edibles I know they're significant to the people it happened to, but statistically, they're insignificant. Recently, we've had a couple of states that legalized pot, and there's been a huge boom in the edible market. So withdrawal, some people actually experience some physiological and psychological withdrawal symptoms. There may be tremor, anxiety, or agitation, but there's no medical interventions. Long-term use of pot, the risk is something called amotivational syndrome. That means you have no motivation and extreme apathy. Recent data says that 30% of those who use marijuana may have some degree of marijuana use disorder. That's a dependence on pot and feelings of irritability and mood swings. Marijuana has been linked to the development of psychiatric disorders with individuals who have a genetic vulnerability. If you click on the word risks in your PowerPoint right here, you'll learn more about that. Most users of marijuana don't go on to use hard drugs, but those who use hard drugs often started with pot. That's why it's called a gateway drug. Studies have shown that in long-term use, 20 years, if you've been using pot for 20 years, you're likely to have your IQ lowered significantly. And let's face it, some people don't have IQ points to lose. Remember, pot is legal in some states. If you happen to go to those states and you see a store that has a green cross outside, that's not a pharmacy. That's a pot store. This drug is not in your textbook, and I'm really disappointed because this is a huge problem. K2, which is also called spice or kush. And for those of you that are right now saying, no, kush is real marijuana. Yes, there is a real marijuana that's called kush. It comes from India or something, but that's not what we're talking about here. Kush now is a term for a synthetic cannabinoid, which is the same thing as K2 or spice. This is not marijuana. Synthetic cannabis was created to study the effects of real cannabis. The reason is the researchers couldn't get their hands legally on pot, so they invented these synthetic compounds. I've got a link to an article about the man that helped spawn the synthetic drug epidemic, they say in the article. Um, Forgotten his full name, John C. Howard, I think, Harwood. He's the man that invented thousands, actually, or at least hundreds of different synthetic cannabinoids. So these synthetic cannabinoids will also bind to the cannabinoid receptors in the brain. And in 2011, they were banned by the DEA, but their chemical formula keeps changing. So it keeps being changed slightly by underground chemists or drug makers. And there are thousands of versions of K2, spice, or kush. So what they do is they take this chemical, the synthetic cannabinoids, spray it on some plant matter that can be burned, and then the smoke is inhaled. K2 is highly addictive and really difficult to quit taking. It costs less than pot, and the effects are more profound and different. K2 in Austin right now is about $10 a hit. This is a crisis in Austin. In early March 2017, there were 33 people taken to the hospital for K2 ingestion, and on your other PowerPoint, you have a link to that article if you'd like to read about it. Please watch that embedded video. That is a real video of somebody after they just inhaled K2. Yes, it's an enormous problem with the homeless, but it's not just the homeless. There are kush parties that are sending young folks to the hospital every weekend. Some actually never recover. Treatment for K2 is supportive fluids, oxygen, ventilators sometimes. If they're on a vent, they're in the ICU. You're going to take care of people whose mind, body, and lives have been ruined by K2. I'm really sorry your book doesn't have information on it. Alcohol. Alcohol is abbreviated as ETOH. So this is going to be the majority of our lecture. Alcohol's prevalence, 66% of American adults sometimes drink, and 12% are heavy drinkers. Your med-surg patients, between 25 and 50% are dependent, and between 50 and 60% of psychiatric inpatients are dependent. Men are usually more affected by alcohol than women, and there is a huge risk in pregnancy. Alcohol is a neurotoxic, and it affects fetal brain development. This causes something called fetal alcohol syndrome. Fetal alcohol syndrome causes mental retardation, delayed growth, and the distinct facial abnormalities you see in these children. They've got this particular type of mouth. You see the bridge of their nose, their eyes, how their ears are. This little fellow's pretty typical of a FAS baby. Let's look at the clinical course for alcoholism. How does it go? Well, first people get intoxicated. Then they have continuing problems with alcohol. They'll experience their first blackout. They won't stop, they'll keep drinking. Then they start to develop tolerance. Then there's a tolerance break. Then they continue drinking. Then their functioning becomes affected. Then they may have periods of abstinence, or they might even temporarily control their drinking. And then there's an escalation of alcohol intake, which leads to more problems, a subsequent crisis, and then a continuation of the cycle. So, shorter version for some of the things to detect alcoholism are the 4 C's: compulsive behaviors, cravings, chronic relapsing brain disorder, and cognitive impairment. So remember, tolerance is when somebody needs greater and greater exposure to receive the same effect. And a tolerance break, what happens during a tolerance break is people need a very small amount of the substance to intoxicate themselves. For most addicts, alcoholism is a chronic illness characterized by remission and relapse. So what do you think is the biggest contributing factor in quitting? It's self-motivation. People need to be motivated to quit. It also helps to have a past history of life successes. So how does this affect your patient? If your patient is homeless, if your patient doesn't hold down jobs, if they already have poor roles in relationships, they have a poor past history of life success. This makes their recovery possibly a little more difficult. Poorer prognosis is associated with the younger something starts, the longer something's been used, if there's comorbidities with other mental illnesses, and remember, addicts have a suicide rate 20% higher than general population. Comorbidities are what you see in this slide. Alcohol gravely affects your liver, your pancreas, and your heart. Wernicke's encephalopathy is a serious neurological condition that results primarily from a deficient of the nutrient thiamine. That's also known as B1, the vitamin B1. The disease is comprised, of 3 main symptoms. Wernicke's encephalopathy. 3 main symptoms: mental confusion, lack of muscle coordination, and a paralysis of the muscles that control eye movements. It is reversible if thiamine treatment is done. Now, Korsakoff's psychosis, however, is not reversible. And something called wet brain is Wernicke-Korsakoff syndrome. It's irreversible. But if they're diagnosed with Wernicke-Korsakoff, it's really important they stop drinking or they'll die. Patients with alcohol substance use disorder also have higher triglycerides, a greater incidence of stroke, higher TB rates, more accidents, suicides, and homicides. Please look over this slide. I love all these pictures. Oh, I know what some of you are saying right now. Oh God, do I have to know all of these labs? No, labs are not on your psych exam. Don't click out of this yet. If you want to be a good nurse, you're going to at least read this slide to understand the labs that are associated with alcoholism and substance abuse. You're going to be taking care of people in the med-surg setting that have it. What a nice slide. So, according to the DSM-5, this is the criteria for alcohol use disorder. The DSM-5 says a substance use disorder describes the problematic pattern of using alcohol or another substance that results in impairment in daily life or noticeable distress. With addiction, despite any consequences suffered by a person without drugs or alcohol, they generally continue to use their drug or alcohol of choice. And their attempts to cut back or stop are usually unsuccessful. So the DSM says that in order to be diagnosed, you have to have 2 of the 11 symptoms within a 12-month period that you see there in the graphic. Please pause your slides and read through these and make some notes for yourself so that you recognize some of them. Remember, alcohol, or ETOH, which is shorthand for alcohol, is a central nervous system depressant. It's rapidly absorbed into the bloodstream, causes relaxation and a loss of inhibitions. think there's a song that says tequila makes your clothes fall off. That's the loss of inhibitions. As intoxication progresses, speech becomes slurred, you become uncoordinated. Click on the video that I've got embedded there. It's a pretty good song about how much your cerebellum loves alcohol. With alcohol, your judgment is impaired and people become inappropriate. People become inappropriate sexually. They become inappropriate aggressively. They laugh. You know, there's the laughing drunk. There's the crying drunk. And did I say they become sexually inappropriate? Yes, that's true. Intoxication can lead to overdose. Overdose can be seen by vomiting, blacking out, respiratory depression, aspiration pneumonia, shock, coma, and death. Long-term use of alcohol causes brain damage, organ damage especially to the liver and pancreas, and can cause psychosis. Please go to your other PowerPoint and watch the short video about how alcohol affects your brain. Symptoms of withdrawal begin a few hours after stopping or markedly reducing alcohol intake. Yes, a few hours sometimes. Withdrawal peaks around day 2 and may be over in 5 days, but frequently it can take more time and sometimes up to weeks. Symptoms with minor withdrawal start out as anxiety, insomnia, nausea, and coarse hand tremors. Some drinkers experience major withdrawal symptoms such as hallucinations, whole body tremors, vomiting, sweating, and hypertension. Seizures can happen. Withdrawal seizures can happen within 6 to 8 hours of alcohol cessation. That means you stop drinking. These seizures are a major motor seizure. Actually, seizures can be your first symptom of withdrawal. So if you get somebody admitted with a sudden seizure, be sure to ask about alcohol use. Symptoms will usually rapidly decrease, or they can lead to DTs, delirium tremens. The video in this link right here, please click on this. This is an actual DT that's happening in an ER. DTs are a medical emergency. They can start 2 to 3 days after cessation and can last 2 to 3 days. Clinical manifestations of DTs include agitation, global confusion, disorientation, hallucinations, fever, hypertension, diaphoresis, and autonomic hyperactivity. That's tachycardia and hypertension. DTs are hallmarked by the profound global confusion that people experience. So why do you guys need to know the symptoms of alcohol withdrawal? You can have a regular med-surg patient who suddenly quits drinking due to surgery. Now, you have a post-op patient who may be experiencing mild to severe symptoms, and you need to be able to recognize it and report it to the doctor or the RN so alcohol withdrawal can be medically managed. Alcohol withdrawal can be life-threatening and should be done under medical supervision, especially with heavy drinkers. So our goals for detox is that detox is going to be safe and comfortable as possible, because our hope is once folks are withdrawn from the alcohol, their motivation for abstinence and recovery is enhanced. So for safe withdrawal, we're going to use this tool. Right here's the link to click on it. It's called a CIWA-AR, C-I-W-A-A-R. That's the Clinical Institute Withdrawal Assessment of Alcohol, revised. It is your most objective and best validated tool to assess the severity of alcohol withdrawal. It's only used on patients who've been drinking recently to assess for withdrawal symptoms. It's a 10-item survey that can be administered in 5 minutes to patients who are coherent and able to answer questions logically. Click on the link again to see the tool. So the 10 items include questions about nausea and vomiting, anxiety, tremors, sweating, auditory disturbances, visual disturbances, tactile disturbances, headache, agitation, and clouding of sensorium. Basically all the things that happen when you become intoxicated, right? 0 to 7 points are assigned to each item, except for the last item, which gets 0 to 4. You can have a total possible score of 67. So scores of 8 or less are called mild withdrawal. Those who have a score of 8 to 15 are treated according to their presenting symptoms, their history, and the doctor's preference. A score of greater than 15 is seen in patients with moderate to severe alcohol withdrawal. Patients with a score greater than 15 or those who have a history of alcohol withdrawal seizures should be treated with medication upon presentation to the facility. They need to be treated immediately. These patients need to be monitored carefully for the development of DTs. What are DTs? Oh, we talked about it in the last slide. Go back and look at that again and watch the video. During a medically supervised alcohol withdrawal, patients are given benzos like benzodiazepine, Librium, or Valium. And those are going to help to suppress the withdrawal symptoms. And then we're also going to use drugs to suppress seizures like Tegretol and Depakote. So we're going to do frequent assessment, and we're going to use the lowest dose possible, tapering off as the withdrawal symptoms subside. Vitamin B1, thiamine, right here on your slide, is given to prevent that Wernicke's encephalopathy. Don't remember what Wernicke's encephalopathy is? Go back a couple slides. We might also use a beta blocker. Beta blockers are only given if they're given with a benzodiazepine, because the beta blockers are going to help reduce some of that autonomic nervous system activity, or ANS. Oh, so many big words. ANS hyperactivity is tremor, tachycardia, elevated blood pressure, and diaphoresis. So a beta blocker will help to control some of these. Now let's get into the nursing process. Mostly in this nursing process, I'm going to keep referring to alcohol. Some of this is also applicable to other drug use. So you'll see this very first grayed out thing that says intervention. I have a saved episode of intervention. Honestly, if you've never been around an addict, please watch this episode. It's really important to understand what it's like for the addict, what it's like for the families, what the process looks like. And this is a particularly good episode, and you may notice that this is a little town in Texas. It's a tiny, used to be mostly farming community that is just southeast of Houston. So, applying the nursing process in the care of clients with substance abuse. Now, it's important that you understand that denial is the central coping mechanism used by substance abuse folks with a substance abuse disorder. We're going to use assessment tools to recognize problems in early stages. We'll use something like the AUDIT, Alcohol Use Disorder Identification Test. The AUDIT test is somewhat long, and there's much shorter tests like the CAGE-AID test, CAGE-AID. If you work in primary care, you're going to probably see the CAGE test, CAGE-AID, or something similar to it used as a screening tool. So now let's get to the slide. Remember, for you as a nurse, you're going to see folks with substance use disorder in all your practice settings. Let's talk about our assessment. What are we going to see in the history? Well, we're going to see a history of some sort of use, right? We're going to ask about their history of use with drugs or alcohol. What are the drugs you take? We talked about this earlier. What's the pattern of usage, the dosage? Did you have previous treatment ever for substance abuse? Do you have blackouts, delirium, seizures, withdrawal symptoms? And when was your last drink? Very important to ask that, because we're going to monitor for withdrawal. In their general history, we may see a chaotic family life. There may be a family history of substance abuse. There may be even a crisis that precipitated treatment. So a crisis is going to be an intervention. An employer or a family member said, you have got to get help, and said it in a way that really affected the person who's addicted, because it's super rare for clients to seek treatment on their own. This is the Cage Aid tool we talked about, and this is the audit tool that we talked about. Please take a look at both of those. What are we going to see for folks in their general appearance and motor behavior? Their appearance may depend on their overall health and the damage the substance has done to their system. Remember the meth mouth. Most are anxious and apprehensive about treatment, and often there's poor self-care, so their appearance may sometimes appear disheveled. For mood and affect, we're going to see that there's a wide range in mood and affect. Some are tearful, some express guilt. There may be remorse, some may be angry, they may be sullen, quiet, or unwilling to talk. And some may appear happy, like happy-go-lucky, especially if they're still in denial. Thought process and content. Substance abusers minimize their addiction. Very important to understand that. Substance abusers are in denial. They minimize their addiction. They may blame others or rationalize their behaviors. And this combination of denial plus rationalization plus blame, or projection, you may recall, blame and projection, are the three most common defense mechanisms: denial, rationalization, and blame. And substance abuse folks with substance use disorder tend to have concrete or all or nothing type of thinking. Continuing in our assessment, in their sensorium and intellectual processes, we're going to see that these are largely intact unless they're high or they're in withdrawal. Judgment and insight, almost every person that has a substance use disorder has very poor judgment. Some have impulsivity, and many believe at any point they have the ability to control their substance use. I could stop at any time. Self-concept. Many have low self-esteem, which they'll frequently cover with grandiosity. They have problems with feelings. They can't cope, and they will self-isolate to avoid pain. Their roles and relationships, you can imagine, are often strained. They avoid conflicts or minimize conflicts and seem maybe passive, but maybe in fact rather manipulative. There's a great deal of dysfunction, and the client may have anger with those who brought them to treatment. Physiologic considerations, I can't overemphasize how poor their nutrition is. Nutrition takes a back seat to getting the substance. So if you have $10, you won't buy food, you'll buy alcohol or drugs. There may be sleep disturbances, liver damage, HIV infections. HIV infections will happen more frequently with those who are IV drug users or those that have turned to prostitution to get their drug of choice. Some will have lung damage as well. So our nursing diagnoses that are appropriate are for the physical and psychosocial care of the person with a substance use disorder. So let's look at their physical health. We're going to look at things like nutrition imbalance, risk for infection, risk for injury, self-care deficits, things along those lines. The book lists a ton of them. And those that are related to their substance abuse, we're looking at things like ineffective denial, ineffective role performance, dysfunctional family processes, and the big one, ineffective coping. Again, your book lists all good nursing diagnoses. Outcomes are things that are going to reflect improved functioning of a client with a substance use disorder. So we're looking for things like the patient will abstain from drug or alcohol, talk openly about their feelings, verbalize acceptance of responsibility for their behavior, practice non-chemical means of dealing with stress, and maybe establish an effective aftercare plan. Okay, big slide coming up. Take a break if you haven't already. Nursing process application, interventions. What will the nurse do? So during detox, which depending on how bad the withdrawal is, this can be either inpatient or outpatient. Nursing interventions on inpatient care are designed to decrease anxiety, decrease stimulation, such as, to decrease anxiety by decreasing stimulation, using clear, simple explanations. You want to explain all the procedures. You want to stick to a schedule. We're going to try to minimize confusion and the altered perceptions. So we're going to monitor their medical status. We're going to do reinforcing of teaching and information. We may use calendars. We may put labels on rooms and things in the room, and we're going to do reality presentation. We need to promote sleep. How do we do that? Decrease stimulation, avoid caffeine, allow rest or sleep as needed. How do we prevent dehydration? Well, we can monitor intake and output, or assign that to our UAP and then monitor what they say. We can administer antiemetics as necessary, and we need to remind folks to drink fluids. To promote nutrition, again, we're going to monitor intake and output and offer small, nutritionally balanced snacks or meals frequently. After detox, to facilitate relapse, the LVN, which is what you guys are going to school for, was going to reinforce teaching for the family and the client about the illness and substance abuse. One of the hardest things for the client and family is they need to understand that they can't go back to their previous lives. There has to be a change in behaviors. You cannot go and associate with the friends you used to party with. As somebody who's recovering from a substance use disorder, you can't handle that. You can't put yourself in the position by partying with people, going and socializing with the people you used to party with. And by party with, I mean get high with. So the nurses also need to educate families about codependence. Codependence is a maladaptive coping behavior where the family covers for the addict. The characteristics of codependence are poor relationship skills, excessive anxiety, worry, and compulsive behaviors. Surprisingly, families are sometimes resistant to change because that role of being a codependent is their role. They're often the fall guy for the addiction. Families have been caregivers for so long, it's really hard for them to adjust to the role shift of not having to take care of the family member with an addiction. Families have got to learn to stop enabling. No more covering up for the addict's behavior. So treatment involves promoting coping skills with the whole family. Everyone needs support. If the whole family doesn't change, then the dysfunctional cycle will go on forever. For the addict, it's necessary that they let go their own mythology about the disease, the denial. I could quit anytime. They've got to let go of that. They need to learn to focus on the here and now instead of ruminating on the guilt and destruction that they've caused. So what do we do for evaluation? Abstinence is the greatest indicator of success. We're also looking for people to find effective ways of coping with stress. Verbalize your feelings instead of drinking them, for instance, and find ways to relax that do not involve a substance. Develop more satisfying emotional relationships and have a better satisfying life. Substance abuse treatment after detox. So we're going to talk about a couple of different treatment models, settings, and also pharmacological treatment to prevent relapse. The Hazelton model, you've got a link to their website right here. I believe they're now called Hazelton Betty Ford. Hazelton says that from their website that 8 out of 10 of their patients experience dramatic improvement, and more than half maintain continuous abstinence for at least 1 year. Hazelton is very similar to the 12 steps of Alcoholics Anonymous. The 12-step model for recovery, 12 steps are used inpatient and outpatient. You don't have to have a medical professional to be involved. This is based on the philosophy that total abstinence is essential. Addicts can't drink a little and be successful in Alcoholics Anonymous. So total abstinence is essential, and you need the help and support of others to maintain your sobriety. Key ideas in the 12-step program include approaching sobriety 1 day at a time, not getting frenzied about daily life and problems, and turning over your life to a higher power. Members attend regular meeting. They can attend open or closed meetings, smoking or non-smoking, gender specific or not meetings. Sometimes there's guest speakers, sometimes there's reading or meditation, but a 12-step meeting offers people battling addiction a chance to seek and offer support for their sobriety. Overall, they offer members a chance to learn methods to cope with stress without the use of a substance. There are offshoots that are family support. Your book gives you a national organization number. The link you've got right here is to the Hill Country chapter. If you or someone you know would like that information. AA also has links to atheist versions if you don't believe in a higher power, and links for support groups like Al-Anon and Alateen. And it's important, remember that the family have support so everyone can change. Treatment settings, those in the throes of intoxication or withdrawal are often treated in the inpatient setting and then referred to appropriate outpatient care where individual and group therapy continues. Some folks need a 30-day residential treatment program if they haven't been able to stay sober. Once they're there, they have 24-hour monitoring and support. I actually have quite a few previous students that are working in those settings and find that work very rewarding. Some folks can stay in their own homes and then do intensive outpatient programs where they meet 3 or 4 times a week for 3 hours a day to get education and therapy to help with coping skills and changing behaviors. That sounds like cognitive behavioral therapy. And some live in halfway houses or a sober house for the needed support and structure that the house that you're sharing with other folks in recovery will provide. So let's look at the pharmacological treatment to prevent relapse. Remember, pharm doesn't cure, it gives people a chance for safe withdrawal and the prevention of relapse. We already talked about the meds used in withdrawal. Please go back and review those. For patients committed to sobriety, the drug Antabuse can be prescribed. That's this one right here, Antabuse. Can be prescribed to deter drinking. If you drink while you're on Antabuse, you'll get a throbbing headache, nausea and vomiting, and in some patients there's such severe reactions that there's been coma and death with drinking with Antabuse. So you've got to have somebody that is definitely committed to their sobriety. Camperol is used to prevent cravings to alcohol. This can't be used in patients with renal insufficiency. Alcoholics, and especially those taking Antabuse, must avoid any products made with alcohol. So what's made with alcohol? Cough syrup, mouthwash, vanilla extract, and other things too. You've got to teach your folks that are in recovery about reading labels. Folks who are recovering from alcohol abuse are frequently prescribed B12 and folate, as well as thiamine to correct nutritional deficiencies. For folks who are in opioid withdrawal, like we talked about before, methadone may be used to satisfy the cravings but not produce the high. And I've got a list here for you of the 12 steps of the 12-step program, so please look that over. Dual diagnosis. A patient with substance abuse and another psychiatric disease is termed to have a dual diagnosis. It's estimated that 50% of those who have substance abuse also have an underlying mental illness. So it kind of makes sense. People may have been using drugs and alcohol to self-treat. So for those patients, some of them might have thought, content, and process impairment, which can be a barrier in some substance abuse programs. If you don't remember thought, content, and process, please go back and read your nursing assessment slides. So schizophrenics can't avoid all substances. For instance, they need their meds. So we look at their recovery as limited in that they don't partake in addictive or non-helpful substances like illicit drugs and alcohol. For healthcare professionals, it could be difficult if the illicit drug or alcohol was the cause of the psychotic behavior, or is the mental illness causing it? So Dual diagnosis patients can be very challenging for the healthcare profession. Let's talk about some considerations for our older folks. About 30 to 60% of elders in treatment don't start drinking abusively until after age 60. So late onset has risk factors, including chronic illness or use of prescription meds, the stressors that people go through later in life, like grief and loss, and older folks have a little more time on their hands if they're not working, and they may have a little more spending money. With older folks who develop substance use disorder, their physical problems develop a lot more quickly and with more severity. Substance abuse in healthcare professionals. You have a legal, ethical, and moral responsibility to report suspicious behavior of your coworkers to your supervisors immediately. You have to ensure patient safety. If you have a coworker who's impaired or who you suspect is impaired, you need to be sure that their patients are cared for and safe. So here's a general list of warning signs. And if you have not done your quiz yet for this module, please do it. General warning signs. Specific behaviors are things like incorrect drug counts, excessive wasting of controlled substances. Patients report ineffective pain relief with that particular nurse. That nurse seems to have a lot of damaged packaging, a lot of pharmacy errors, and they're always willing to go pick up the controlled substances. They may also be missing from work. Oh, they're there, but they're in the bathroom an awful lot. You have a link here to TPAPN. This is peer assistance for addicted nurses. TPAPN is not punitive, it's confidential, and it's a voluntary alternative for RNs, nurse practitioners, and LVNs with concerns related to substance use and mental health. This is our alternative discipline program here in Texas. TPAPN has good results. About 30% of nurses who participate in it return to work. Understand that before these alternative to discipline programs, that number was near zero. So I'll ask you again, as I did at the beginning, please examine your own beliefs and behavior about alcohol and drugs. Think about what your own feelings and attitudes are for the families and the clients with substance use and abuse. Think about how this affects society. Think about how it affects nursing and medicine. And please remain objective and reasonably optimistic about people's chances for recovery. And if you're having difficulty, talk with your coworkers about it.